I am a nurse practitioner, and I have a board certification in psych, mental health, and also family practice. So I have a kind of a unique role in that I'm dually certified. That's a nice combination in the rural environment that I practice because I can see individuals for medical needs as well as for mental health issues. My certification allows me to, and my licensure, allows me to prescribe medications, to diagnose, to treat, and also to do some basic counseling. So it is a good fit for a rural practice. I started out my career pursuing nursing, and I actually graduated as a registered nurse, and I worked actually in coronary care for many years, and then got into more of general medical surgical and moved from an urban setting to a rural setting. After being a registered nurse for, at least 15 years, I decided to advance my degree, and I went back and got a master's degree in nursing and completed the nurse practitioner program with an emphasis in family practice. So I came out and I started working in a family practice clinic doing just general primary care with families. And I saw that psychological problems, mental illnesses, and all of the psychological issues that people deal with and the social issues that people deal with are very difficult to separate from their physical illnesses. There are very few mental health practitioners out in the rural area, and when I became aware of the psych mental health certification that I could receive as a nurse practitioner, then I went back to University of Nebraska Medical Center in Omaha and completed another 2 years, and it was actually a postmaster's certification in psych mental health. And that allowed me then to come out and deal with the mental health issues, hopefully in a more competent way. I think still in family practice we deal with those issues on a day-to-day basis, but now I have received a little more expertise and advanced training in that area. I think I took a long path to get where I am today, doing it by increments, and I did that because I had a family, and it's what worked into my life at the time, and I'm thankful that there was a way to get to this point, a little bit at a time. I'd really encourage anybody who has the interest early on to do it right out of college and to continue to pursue it and get to this point. But it can be done in another way. And really, I'm not sure that 20 years ago that I was ready to deal with mental health. I was really not interested in it. I think I even remember telling friends when I graduated from nursing school, oh my gosh, I'll never do psychiatry. That would never be an area that I wanted to practice. But I think as I grew and matured and learned to deal with people, that it just came about through that. I think in Nebraska, a lot of people don't really know what a nurse practitioner is. They tend to know that we're not physicians, but they think maybe that we're physician assistants like PAs, because PAs have really, I think, been around and practicing more, especially in rural areas, than nurse practitioners. So people don't exactly know who we are and what we do. And so I always say, well, we're sort of like PAs, but our training model is different. We're trained in a nursing model, which I always say is more like a health and wellness model, versus the physicians and PAs who are trained more in a medical illness and disease type of model. So there's a little bit difference in our training backgrounds, but in terms of our day-to-day functioning, I still have the scope of practice that allows me to diagnose, to treat, and to prescribe. So not everyone knows that I can do that. The education doesn't stop when you get your degree and your board certification. I have a national certification which I am required to keep current, and that's a state requirement that I do that to maintain my licensure. My state licensure, I have to have 40 hours of continuing education every 2 years. The national standards, those hours vary depending on which organization certifies you. So it's still a minimum of continuing education every year that you have to complete, including active practice. So you have to stay in the profession. I think I learned that this was the best fit for me. Within family practice, there are a lot of physicians that really do like to deal with the medical complex things within medicine and don't get into the psychosocial stuff so much. But I think for me personally, it was a good fit, and that's what drew me to this. And again, because there just was such a need for mental health providers, even being where we are, a 40-minute drive for someone can be a barrier to getting care. And if they don't have to do that and can stay in their local community, then I think that's wonderful for patient care. I think there's going to continue to be a need for mental health nurse practitioners, especially in rural areas, because we just don't have the population base to support a full-time psychiatrist. They have to be located in a higher patient population than we have here. And so I don't think we're going to be able to attract psychiatrists, and even if they're 50 to 75 miles away, it's too far for many people to drive. And so I think that the mental health nurse practitioners will fill a niche because they are able to prescribe the medications, and they can do some patient counseling as well. And then those patients that need more intense counseling, I always refer those on to the psychologists, to the licensed mental health practitioners. I use psychologists frequently in my practice to do a lot of evaluation and testing. And then certainly there are complex psychiatric patients that I can't deal with, and then we send them on to the psychiatrist. And the other piece of that is that we don't have any inpatient psychiatric care available in the rural areas. And so we try to do what we can on an outpatient basis, but then when someone needs the inpatient care, then we have to refer them on. When I started my practice as a psych NP, we really didn't know what the need would be and how quickly my schedule would fill. But if we look back over the years, the patient numbers have continued to grow. A lot of that is now because the local physicians know that this is my area of interest and expertise. They'll refer their patients to me. I also see a number of patients from other providers in other communities in the area, and they'll refer them. And for those individuals, I just deal with the mental health piece, and then they see their family doctor for their other care. And so yes, I think that the need is there. I'm hoping that we're decreasing the stigma of people getting treatment, and that we're dealing with issues sooner, rather than waiting until people get into real trouble. But my practice, I will see sometimes as young as age 3, up through geriatrics. I go to all the area nursing homes one time a month and deal with issues that affect our older adults, including depression and dementia, longstanding mental illnesses, behavior issues. So there's always going to be a need, I think. A typical clinic day for me will generally start around 8 in the morning, and I spend my first hour returning phone calls and following up on things from the day before. And then my schedule is a little different than, say, a physician in our family practice clinic. They have briefer visits, maybe scheduled every 15 minutes, which I think is pretty common in most practices. My visits tend to be closer to a half hour each, and they're scheduled that way, just because to get to the heart of all of the issues with patients, that takes a little bit longer. And an initial visit, rather than a half hour maybe for your full physical, for me it might be an hour blocked out, because we try to get as much information we can. And another difference in the mental health aspect versus just the primary care is that you have to develop that relationship with the person before they trust you to really divulge all of the things that are really going on. So sometimes at that first visit, we'll just see the tip of the iceberg and maybe the huge glaring issue, but there's a lot of layers that we peel off over time. Another population that I have dealt with a little bit more is those people who deal with chronic pain, which we tend in primary care to see that as really a medical issue, but oftentimes there's a lot that it lies underneath of that there is a psychological, a social. It affects all aspects of their life, and that's another unique population that we deal with. The most rewarding part of what I do is to see that person that I saw a couple of months ago who comes in and is having to drag themselves out of bed every day and really can't see beyond today. And then for them to come in and say, I feel like a new person. I've turned the corner. I'm back at work. Family life is good, and that to me is really rewarding. And it is the most challenging part of what I do. And I always tell people, if I had a magic wand and I could wave it and you could feel wonderful tomorrow, and I'd be a rich lady. It's a long process. People didn't get depressed overnight. These problems didn't develop overnight. It's a slow process, and it really is a partnership with the patient. I think when I was younger, I had this idealized idea of what everybody's life should look like, and it should look, more like mine. But the more that you do this, you realize that people are so unique, and their living situations are so different, and the issues that they deal with are so different, and you really have to meet people where they are and then move forward. And their goals may not be the same as my goals, but together you work on what makes life better for the patient. I'm often asked by especially high school students what kinds of coursework they should be taking, what kinds of activities they should be doing if this is what they want to do for a career. What I do, you have to be a nurse first. So it would be whatever is the curriculum for the nursing schools. And so that's the basic sciences. It's also good to take some psychology, maybe sociology, those types of things. But your basic, gen eds and core college curriculum, I would strongly encourage anyone that thinks that they're going to do this to not think about, I'm just getting an associate's degree. You need to go into it thinking, I'm going for a 4-year degree, because that's never going to be enough. You're going to have to go with your sights set on the master's degree, and even some have doctorate degrees in nursing, and so that's farther down the road. But you have to enjoy those basic sciences, and certainly the psychology aspect if you're going to get into mental health. And you have to have an openness and willingness to work with people, and all types of people. I think some people think that in mental health, you have to be tender-hearted and loving and all of that. I think it's about you need to know who you are as a person. You can't be a pushover, because you have to set boundaries with people, and you have to, I think, have some good insight. You have to be able to make good decisions. You have to be able to admit you're wrong and that you don't have all the answers. You have to be a good listener, and that's a skill that we all have to work on. But and learning to be a good communicator is another thing, because when people are in distress, they only hear a fraction of what you say. So you have to have some good communication skills. I think one basic thing that is helpful that a lot of nursing programs are requiring is working as a CNA, or having that experience working in a healthcare environment, maybe even in a volunteer role or shadowing experience. I think if students can do that, that's great. It's more challenging to shadow in the mental health setting, however, because people are less open to having you sit in on visits. And so that does make this field probably a bit more challenging than other healthcare professions. One unique thing about the way that we do mental health in our rural community is that we have it integrated right into our family practice clinic. This works well for a number of reasons. First, it's nice and convenient and allows me to collaborate and communicate well with the physicians that I work with. Also eliminates the need for extra staff. But more importantly, we'd like to believe that it decreases the stigma for getting help. People come into our clinic and no one knows whether they're there to see me or whether they're there to see their primary care doc. They sit in the same waiting room, they're called back by the nurses just like every other patient. They're weighed and measured just like everybody else and taken back to the room, and nobody knows that they're there to see me. Their car's not parked out just outside of somebody's private office, and it's very hard in rural areas where everybody knows everybody to come for help. And so we'd like to believe that this is a really positive thing for patients, that they can get the care and have that stigma reduced.